Our next talk is Daniel Silman, who's going to talk to us about Keticap immediate release formulation.
Thank you. Everyone can hear me okay? Yep. Great. Great. Okay, so something in the same territory, but with a slightly different angle. So it's a great privilege to be here to present this first-in-human data of a immediate release ketamine formulation, which has been developed by our study sponsor, Neurocentrx. So I don't have any relationships to the sponsor to disclose. I am a research fellow at King's and an MD Res student, which is where the study was conducted. And so I was a study doctor supporting our PI, Dr. Mario Gerena, who is also leading our ketamine service there. So oral ketamine, just very quickly, I don't want to open up too many wounds from Monday's debate, but just to say that at the Maudsley Clinic, we are making use of oral treatments, including at home, including sublingual ketamine. So you can see we do have facility to administer other routes of ketamine in our ECT clinic, including subcutaneous ketamine. That we do weekly from our severe patients, but it is oral ketamine that's currently the bulk of our treatment, with sort of convenience being a big driving factor, particularly for patients that live away from London, looking to return to work, that side of thing. And IV and nasal ketamine is largely being used in clinical trials in our centre. So it's well known to everyone in this room that our current use of oral ketamine is really limited by a lack of PK and PD data, which is why having a new product to do detailed evaluation is very welcome to get that key data. So just to say about the product, there's a different angle from the last talk. It's developed by Neurocentrx. It's an oral capsule of racemic ketamine, specifically formulated to be immediate release, rapid acting, so trying to mimic the pharmacological profile, as I understand, of the established routes of IV and intranasal, theoretically giving the best chance of replicating the efficacy of those routes. I think I'll save any, as a clinician, I'll save any questions about the sort of pharmaceutical and excipients to people that know more than me on that. So this is our study design. So just very briefly, so we recruited in July of 2022 up until February of the following year. It was at the King's CRF. So our healthy volunteer population was fairly standard. We did allow minor, well-controlled physical health problems. We did actually control for metabolizer status by doing genotyping and excluding patients that were at the extremes of metabolism. We gave 3 blinded doses of ketamine in a dose escalation, which I'll describe, and then did a fairly standardized set of monitoring and assessments, including the usual battery of PD assessments. So safety and tolerability was primary, and the PK and PD were our secondary outcomes. So this is how the dosing worked. So we had point on. Okay. Right, yeah.
This one. You want the pointer, right?
Yes. There we go. Okay, so yeah, we had 2 treatment cohorts of 9 participants each. So we had a low-dose cohort escalating from 40 to 120 milligrams. So it was split into 3 subgroups of 3, where each dosing 1 would get placebo and 2 active. So a total of 6 getting active treatment for each dose. And our higher dose group escalated from 160 to 240. So dosing procedure, participants came in for a 2-night stay so that they could be fasted from midnight until 4 hours after. After the 24 hours of monitoring, they'd be discharged and would have a 7-day washout before coming back for next dose. And so monitoring was fairly standard. We did cardiac monitoring with vital signs, serial ECG for 4 hours, and telemetry up till 12 hours. And then our PD assessments at 1 hour, 4 hours, and 24 hours with blood and urine collected over the 24 hours for the PK. So our study population, so our final N of 19 does include one participant that was withdrawn. They received a placebo and no active treatment, and then failed a urine drug screen. So they were replaced, so we had our full complement of 18 volunteers getting all the doses and giving a full data set. Our characteristics were quite unremarkable. I will point out that the higher dose group did, there was a higher number of recording their ethnicity as white compared to the lower dose, but otherwise unremarkable. So I'll start with the safety. So overall, 85 AEs across the study population. As you'd expect, the vast majority, 94%, were in the active treatment group. And all patients receiving 120 milligrams or more did report at least one AE, with a tendency for more AEs per participant at these higher doses. Vast majority, 86%, were causality assigned as at least probably related to the ketamine. But in terms of the clinical significance, so no AEs were severe or serious or led to treatment discontinuation or adjustments, and most significantly, no clinically significant cardiovascular or lab changes. So just running through by system, so starting with cardiac, because that was deemed data of special interest, we had 3 AEs, so 2 of tachycardia, 1 mild and 1 moderate that were deemed related, 1 instance of extrasystole or ectopic, which was thought to be incidental. The blood pressure changes were all, there were some blood pressure changes in the higher doses above 120 milligrams, deemed minor, mean change of 18/11, and all had resolved by 4 hours, and there were no other ECG or telemetry changes. Of the other systems, so nausea was fairly common. We had 7 participants, and that was not obviously dose proportional, although we did have 2 instances of vomiting in the towards the higher doses, and one of those, given metoclopramide, was our only rescue medication used in the study. Of the other symptoms, dizziness was seen in 10 participants. That was perhaps dose proportional. Headache was seen in 9 participants distributed across all of the doses. Within the psychiatric symptom cluster, most relevant would be dissociation, which we saw in 26 out of the 36 active doses. I'll run through the CAD score, but 10 participants rated that as moderate, so it would have been two participants in each of the middle dose groups and 3 out of the 6 in the higher dose groups. Okay, so now the main PK outcomes. So starting with the intact drug R and the S. So the red strips, you have to excuse, there's a discrepancy. The graphs is geometric mean and this table is the arithmetic mean. Apologies for that. But so the red strips show that the Cmax of the parent drugs did increase dose proportionally up to a plateau. Where have you gone? There. Of around 111 nanograms per mil at the 200 of the R and 96 of the S. Drug exposure, AUC, increased dose proportionally, and the peak time Tmax was around 1 hour at all doses, 1.6 in the higher dose group. So we have included some preliminary and exploratory comparison to PK data of other formulations that have been previously published. As I say, this is quite qualitative and exploratory, but for some indication. So this is total RNS against IV racemic in a TRD population from Singh et al. And we can see that the 1 hour and peak and 6 hour levels are roughly comparable with the higher dose groups of the immediate release oral ketamine. And then this is just S-ketamine in comparison to intranasal from publication from Kurosawa et al. And that the same profile looks to be in the range sort of between the 56 and 84 of intranasal, with the 200 of Ketir probably coming closest to the 84 milligrams Cmax. And so metabolites, just to say, they all increase dose proportionally as well. So this data is from the 240 milligram group, where our norketamine had the highest Cmax. 2R6R, HNK, was the slowest eliminated, had the highest exposure. So around 12 hours, there was 50% clearance and some residual drug metabolite at the 24 hours, with a Tmax of 4 to 5 hours for the 2R6R. Dissociation was seen at all dose levels, although very negligible in the lower doses. The top 2 doses had the same mean change on the CADS at 21, was largely resolved by 4 hours. There were a couple of participants did report some mild residual symptoms, which was responsible for that, not quite at baseline there. Similarly, the PSI, which is this graph here, showed peak at 1 hour. That looked dose proportional for the lower doses, but before plateauing as well. Bond and Lader, the baseline started fairly high for this, and we saw 1 hour peak reduction there before nearly resolving at the 4 hours. And again, on the right, you can see the sort of dose proportionality in the lower doses before a plateau. This just demonstrates mainly driven by that alertness factor. There was no concerns with sedation. Our sedation score stayed at the maximum at all time points. There was a noticeable effect on cognitive performance from the ketamine, but this was quite heterogeneous and didn't really relate to dose or time since the dose. So final exploratory results to share. So this is kind of looking at the relationship of drug exposure as indicated by Cmax with some of the psychoactive changes. So starting with the Bond Lader, we've plotted R-ketamine on the left and the 2R6R HNK on the right. So you can see there was a moderate negative correlation with the R-ketamine, an R of minus 0.37, and less of a relationship with the metabolite, suggesting it might have a less of a mediating effect. And we did the same on the CADS for dissociation, so higher correlation with the R-ketamine Cmax of 0.54, and then kind of no relationship at all for the 2R6R HNK. So that's it for the results. I'll just emphasize some summary findings. So I guess obvious limitations with a phase 1 study with small numbers, very controlled conditions. We don't know if these PK and PD findings would generalize to TRD patients. But we can say that from this phase 1 data that the doses tested were all safe and generally well tolerated up to 240 milligrams. The PK profile was dose proportional and seemed to follow a rapid acting product as expected, and our PD changes were sort of within the expected range for ketamine use. And lastly, this is the sort of development pipeline from Neurocentrx, basically just to emphasize that there'll be phase 1 testing of a similar abuse deterrent formulation of the Ketir that will go into clinical efficacy testing in both bipolar and unipolar, and that should include some at-home testing as well. So that is it. So many thanks. And yeah, happy to take questions.
Fantastic. Thank you, Daniel. Does anyone have any questions at all?
Are you aiming for at-home use with a nurse present?
I think it's still TBC, is fair to say. I think perhaps Mitchell might comment as well, but I think as part of the development, patients would start with in-clinic dosing to assess tolerability before moving on to at-home, and whether the at-home is sort of augmented by, I don't know, some sort of health professional visit or tech or something. I think that's where we're at the moment.
Yeah, so just as actually a follow-up to Rupert's question. So it looked like the MOAS stayed at 5 for everybody? Because that would be surprised if the CADS is pretty much identical to what you would see with 0.5 mg per kg dose. So that's unique if that can be replicated, because typically you'd see at least MOAS is in the 4. Yeah.
Yeah, that's fair. I mean, yeah, I can't comment to all the data. I guess maybe it might be a limit of when it was done in terms of being done at certain time points. It was done at 1 hour and 4 hours, and maybe that's too cross-sectional and wasn't then capturing any changes that could have occurred before then, perhaps.
Well, it's good. Wait, half is good.
Yes, thanks for the interesting talk. You're talking about a immediate release formulation, but do you expect any difference when you just swallow the IV fluid, for example?
That's a good point. Well, I think in terms of the preparation, maybe there might be more first-pass metabolism if it's just a liquid that gets absorbed like that. Yeah, it's a good question. Perhaps one to discuss with Neurocentrx in the break.
I've got a quick question. What are you going to do about the extreme metabolizers that you excluded? Because they'll be in your patients, right? So.
Yeah, and that's a fair point. I think, I don't think it would be an exclusion in phase 2 testing for sure. Probably, and maybe it would still hold in the phase 1 of the biosimilar. But yeah, I think whether there's scope to do like a subgroup of getting some PK data in a phase 2 study that gives that data for people with more different metabolizer statuses.
Fantastic. Thank you very much, Daniel.
Cool.